Yeah, good morning to everyone from India. Here is a 85 years old gentleman presented with severe calcific aortic stenosis. He has symptoms of NOHA class 3 dyspnea and angina on exertion. LV function was normal. He was a known diabetic and hypertension, and he underwent 7 years back surgery for carcinoma of larynx and followed by radiotherapy. His STS score was 4.16 and
Don't
Euro
move
score
this
was
wire, please.
3.71, which brings this patient into somewhat
Give them the
intermediate
switch.
risk category for surgical aortic valve replacement. So coming to the CT imaging, if we see the annulus, there was two nodular calcium, one at 9 o'clock and one at 12 o'clock at the annulus. So we took two measurements. One is excluding the calcium, which gives a perimeter of 63 millimeter and area of 307 millimeter. When we include the calcium nodules, it gives a perimeter of 67.8 and area of 350. So, which somewhere falls around 23 millimeter balloon expandable valve, or it's going to be 26 millimeter self-expandable valve. So this is a bicuspid aortic valve we can clearly see here, and there is a fusion of the raphe between the RCC and NCC. So it is a Siever's type 1 bicuspid valve with the fusion of raphe between RCC and NCC. And the raphe is severely calcified raphe, which we can clearly see 8 millimeter above the annulus, which is very important because when we deploy any valve, the valve is going to be pushed towards the left coronary, so which is a high risk for coronary occlusion. And intercommissural distance at 4 millimeter above the annulus comes 22.9. So everywhere the size is going to be either 23 millimeter balloon expandable or 26 millimeter self-expandable valve. Coming to the coronary heights, is a high risk for coronary occlusion because the left coronary height is coming 9 millimeter and right coronary height is 11 millimeter.
Are you?
But the sinotubular junction is little high, 18.6 millimeter on the left side and 15.5 millimeter on the right side. The left coronary cusp length itself is 16 millimeter. So if this 16 millimeter left coronary cusp going to push towards the left coronary ostium, especially when there is a fused calcified raphe at the RCC and NCC, though there is a wide aortic sinus on the left side, there is a high chance this leaflet may fall on top of the left coronary ostium. So in short, there is a high risk for left coronary occlusion, whereas right coronary is 11 millimeter, very less likely to get occluded. So sinus of Valsalva width, if we measure, again, if we exclude the calcified raphe, because we are pretty sure that calcified raphe is not going to give away during our transcatheter valve deployment. So by excluding that, the sinus of Valsalva left comes only 24.8 millimeter, the sinus of Valsalva width. And the another interesting thing is here, if you see the right side picture, the last picture, there is a calcium in the NCC, which is penetrating into the membranous septum. His baseline ECG is narrow QRS, no evidence of left bundle branch block, and no PR prolongation. But this left non-coronary cusp calcium penetrating into the membranous septum is the high risk indicator for future pacemaker.
So there are multiple issues here. One is related to the CT, which shows calcium. The second issue is related to the height of the coronary, where the left coronary is short origin. It's about 9. So we need to maybe protect. And the final thing is related to the chance of paravalvular leak. So we have done the following things. We've taken bilateral femoral access, the right access for deploying the valve and balloon dilatation. The left, we took 2 femoral accesses because the radial had spasm. And we have put a guiding catheter JL4 into the left main with a guideliner there. The guideliner is damping the coronary ostium, but we will keep it just at the left main. There's a wire down into the circumflex, and we'll get a 4 millimeter stent down there in case the coronary closes. We also put the second femoral access, the pigtail, to check the aortic angio in the NCC. Yeah, so that's the pigtail angiogram of the NCC. You can see that it's a severely calcific aortic valve. The peak gradient is on the echo 122, and the mean gradient was about 70. So we kept that through the left femoral in the NCC. The second thing we have done is we've got the guiding catheter just in the left. Just can we just go? Okay, so there's a guiding catheter. You can see that the guiding catheter is the left main JL. The guideliner we pulled back, and we're now going to put a balloon, stent down there, a 4 millimeter, just in case we need any protection. In the meantime, Ashish crossed the aortic valve, and we have a mean gradient of 60, I think 57 across that. So we have crossed it and kept the wire, small safari, strong wire down into the. So our plan is now to pre-dilate after I get this stent across into the circumflex, and then show you a metal valve deployment. So
here we have chosen a balloon expandable valve over self-expandable valve, because whenever we protect the coronary ostium, if we deploy a self-expandable valve, we need to recross once again. And we have selected a valve known as Octacore from a Merrill company, which has got a outer skirt, which is mainly useful to reduce the paravalvular leak. So here we have chosen the 23 millimeter balloon expandable Merrill My valve, which is a Octacore.
So can we see the picture of the metal valve Octacore there? You can see that it's there is a valve which has two parts, the open cell and the closed cell, which is 50% each. It has got a nice sleeve on the lower end, which prevents the paravalvular leak. The advantages of this valve is that it has a nice sleeve which protects against paravalvular leaks. The second thing is it does help us to prevent any shortening. This valve doesn't shorten, and that's a very good thing about the valve. And so I think there are three advantages. I can position the valve nicely. Now what we're going to do is pre-dilate with an 18 millimeter balloon. So we've crossed the valve. Can we now pace, please? Yeah. Okay, now we're going to do a pacing. I'm going to take the call. And so, Ravi, please pace at 180 now, please. Okay, the pressure is down. Now, please go ahead. Dilatation and inject, please. Okay, so there is still some flow. Hopefully, pull the balloon back.
Stop pacing.
Stop pacing. Yeah. Okay, so we pulled the guiding catheter out, the guideline out, kept the stent right in, and we're just leaving it at the mouth in case we need to. So let's play that last shot back. So you can see an 18 millimeter balloon coming up nicely. And there is some flow at 18. So let's see what happens. Anyway, the pressure is good. We can't see the white part occluding at this point of time. I can't see it.
But balloon is pushed towards the left coronary. We can see clearly the non-coronary side, it is not giving away. It is moving towards the left coronary.
So that's a very interesting observation that we have. It's a right non-coronary fusion with a lot of calcium, and we expect the balloon and the stent to move towards the left. So the risk of closure is there. And so we need to be a bit careful. Okay, so now we are ready, and we are going to use the audio 15, audio 7 cranial 17. That's the coplanar view, where we're going to deploy the valve. It looks sort of more or less in the same level. Hemodynamics are good. So I think the questions here are, why not some other valve? The idea is, if you use a self-expandable valve, there are a few issues. One, regarding coronary accesses in the future. Number two, the short coronary, we just would, have a problem with the adjustment of the valve. We don't want it too deep because there's calcium there, and we could get into trouble with the CHP, complete heart block. A coronary protection, there's a guiding in, we use a wire, and we get the stent through a guideline. Now we're going to get this valve in. As I said, this is a 23 millimeter my valve auto. Okay, so the valve is clicked in. We're watching, and I'm going to get the guideliner once he comes close to the ascending aorta. Remove the loader, please. Okay, so this is just coming out of the sheet now. So it was a bit tight there. Okay. So we'll flex the sheet as it comes through. Yeah. Okay. It's flexed nicely, and you can see how nicely it was flexed. The catheter will move. Please go ahead, Ashish. Okay. So this is the advantage of the system, that the flexure allows
Show the LV
slowly
wire.
stop.
LV wire. Show the LV
Show
wire.
the LV wire, please. Yeah, that's perfect. Okay. Now I like the valve to cross the guiding catheter and then get the guideline, huh? Because otherwise what happens is when the valve is crossing, you may have a problem with the guiding catheter coming out. So I'm now reintroducing the guiding catheter. And so these are the issues which you'll see. I think this is enough.
Okay.
I think we have enough strength. Okay, let's go down with the valve.
Yeah, 1 second, I will
Slightly unflex. Yeah,
okay.
that's good. Please go ahead. You can see it's a tight valve. Okay. Yes, just gently put the pressure on, it'll go. Yeah. So what we do here is we gently put the pressure as we withdraw the wire into the left ventricle, and this gentle pressure always helps. This is a heavily calcified valve. You can see the horizontality of the valve is what's creating the problem, but I think it's gently crossing.
Yeah.
Okay, that's it. Pull
I
the
will.
wire back and get ready for an
That's okay.
aortogram, please. Yeah.
Pressures are not there. Pressures are
Yeah,
not
so let's see the pressures. We need to support the pressure. We need to go quickly. Okay, I'm just pulling the guideliner back a bit.
That's okay, sir. Guideliner is okay.
Okay. Let's go ahead now. Take the shot quickly. Yeah. Yeah, very quickly we need to
angle.
deploy.
Yeah. Correct. Implanter angle only. Come on. Cine.
Cine, please.
Cine.
You can see how tight the valve is.
So we need to
Go
go
in a
little
bit.
down.
Yeah. Okay.
Slowly.
One more shot, please.
Okay.
One more shot, please.
Yeah,
Okay,
I think we are good to go, sir. We are
okay.
good to go.
Okay, so we're going to, I'm taking the call. So, yeah, keep it all muddled up. Everybody is okay. Okay, so just space now. Okay,
Go, sir.
go up, please. Go up, 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 go 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 go.
1001, 1002, 1003. I'm
Yeah,
deflating.
deflate. There is BF.
Yeah, we'll bring back the stent. Remove the wire also.
So we got everything out now. And now we'll remove the pigtail.
Wire.
1 minute.
We'll take one more shot. We'll see how now.
Yes, please.
1 second, right. Fluoro check.
Okay, that's good. Take one shot, please. Just see sure that the coronaries are okay. The coronaries are flowing well, no problem there. So now I need a wire for removing the pigtail, please. So we get about 2 to 3% of patients getting into
Just push the sheet in.
getting into a ventricular arrhythmia when we deploy the valve. And this is usually in tight valves. Okay, so the valve is out of the way, the wire in the position, and we'll take an aortogram now. So are we all ready for the aortogram, please? Yeah.
Okay, sir, we will align the valve little bit. We will remove the parallax. Fluoro.
So just looking at the coronary alignment now with this valve.
Yeah, I think it's okay. Okay. Move the table.
Okay, so are we ready for the aortogram?
No, it is moved now.
So very beautiful implant. Absolutely no paravalvular leak. No coronary obstruction. The coronaries look good. No AR and no paravalvular leak. And I think we've done a good procedure. What do you think, Nanda?
Yes, sir.
What do you think about the coronary alignment?
So, in fact, actually, the valve braked a little bit RAFE and moved towards the NCC. We thought that calcified raphe will not give away. In fact, the calcified raphe given away. So the valve did not shift towards the left.
Okay, so it was well worth the trouble of getting a guideliner and guiding in. And now we're going to get this valve out. Just so you can see he's back in his normal rhythm. I think the PR is a bit prolonged, but he's okay.
So what is your plan for keeping the TPA for this particular patient?
Well, let me just have a look. We'll keep the TPI anyway till he's in this ICU, and maybe in the evening when you're removing the other arterial sheets. So we're going to close the perc close on the right side and one of the sheets with a and when you're removing the other arterial sheath on the left side, I may remove the pacing wire too. So we may just keep it for a little longer. Normally I don't keep it in. Okay, so we're going to give you an LV aorta gradient. Can we show the hemodynamics now? Okay, so this is the LV aorta. Can we flush both lines, please? Yeah.
I need a flush.
Well, it looks good. I didn't think there's any significant mean gradient here. Just going to flush it and give you the pressures properly. Okay, so we got a good result. And I'm just going to pull back the pigtail catheter from the left ventricle into the aorta. And so I think we're done with this case. We anticipated a few problems. Nothing happened except for that brief VF. And apart from that, we had nothing. So get a wire, please remove that. So just to summarize this case, 85-year-old gentleman with severe aortic stenosis, calcified bicuspid valve, right and non-coronary effusion, with significant calcification, 2 nodules, one protruding into the LVOT, and a lot of calcium within the valve, worrying us whether we would get a paravalvular leak or number 2, complete heart block because of the protrusion. We also had a coronary which was less height, left coronary which is about 9 millimeter. We planned it carefully, putting the guiding catheter, guideliner and stent preventively into the left coronary ostium in case the left closes. Cross the valve and balloon dilated with an 18 millimeter balloon, which showed no occlusion of the left coronary at that point of time, but that does not preclude during the stent. Got a 23 millimeter Aortic my valve, which is an Indian valve, placed across the aortic valve, carefully saying about 70-30 with a post-dilatation was not required in this patient. Following the valve deployment, we had no AR and no significant other hemodynamics except a short VF, which was defibrillated with a short CPR. And the procedure post-angiogram shows an excellent deployment with no AR and no paravalvular leak. Now the plan is to remove the right sheath with a perclose, left one sheath with a plug, and watch for any conduction disturbance. Right now there isn't, except the P is a bit long, and remove all the sheets out, hopefully tomorrow in the ward and in a couple of days home. So we'll close the right perclose, and the patient was done under conscious sedation, so we'll reverse the patients off the sedation in a couple of hours after the groin is sealed, and then follow it up with an ICU stay of a day or 2.